is 4 out of 5. I did not manual muscle test those. Flexor digitorum longus, flexor digitorum brevis. 4 out of 5. 4 out of 5. Extensor hallucis longus and brevis, flexor hallucis longus, flexor hallucis brevis produce pain at first MTP with minimum resistance and heel raise. That's right. So gastrocnemius MMT. I'm gonna have to deal with you in a second. So extensor hallucis longus, extensor hallucis brevis, pain with minimum resistance. Extensor hallucis longus, pain, min resistance. Extensor hallucis longus, extensor hallucis brevis. Flexor hallucis longus, flexor hallucis brevis. So my initial observations or hypothesis for both of these actually remain up in the air. Gastroc and soleus, 5 out of 5. Okay, I still want to get a rub in because I did that wrong. Gastroc soleus, 5 out of 5. 5 out of 5. This patient would not be able to do 5 out of 5. Gastroc soleus with this pain, but whatever. Extensor digitorum longus, extensor digitorum brevis. So that was 4 out of 5. Extensor digitorum longus and brevis is 5 out of 5. Okay, so here we go. That's for MSTT is done, MLT is done, MMT is done. Now I just have to do palpation for tenderness to finish. What?
We didn't do that first.
I do palpation for tenderness last. That and special tests.
Really, it seems weird.
You do palpation for condition first. So I'm going to do manual muscle test of the gastric soleus complex. So if you could stand over here, please. This is the most outrageous manual muscle test of all the manual muscle tests. So I need you to turn around, face the table. We are going to test your unaffected side first. So that would be your right side. So I'm going to demo this. You're going to have just fingers on the table. You're going to raise your left foot. You have to go up 20 times on your right foot. What number are you at?
10.
10. Give it another 10, please. Nice and slow. Slow on the way back down.
Okay.
That was 17.
It was not.
Okay. So that would be 5 out of 5 for gastric soleus. Huh? On that side. Nice and slow. You want to do the eccentric. So eccentric strengthening is important. You think you're not going to do that?
No.
It's important if you want to strengthen your gastric soleus. Come on. You should care. So I'm going to do palpation for tenderness now. So once you're done with your 20 calf raises on that side, I'm going to ask you to lay on your back. I'll give you back the Lappy Tappy. Not Mr. Tabletto, Mr. Lappy. So then, palpation for tenderness. So I've determined hypomobility and hypermobility. Hypomobility at the first MTP, hypermobility at the first ray. So again, I'm testing the right side. I would test bilaterally, testing the unaffected side first. So I'm doing palpation for tenderness. I'm going to palpate for tenderness the extensor hallucis longus tendon. So if you could extend your big toe, please. Good. I'm going to palpate the tendon and just past the ankle, all the way down the foot, up into the big toe. Good. Then I'm going to have you push down on your toe, please, or push your toe down. Good. So I'm going to palpate the flexor hallucis longus tendon at the bottom of the first toe, and then palpate down into the foot as well. Excellent. So I could also palpate behind the ankle. So if you could put your foot down, please, and then also bring it this way. Excellent. So I can feel it come right through there. That's the flexor hallucis longus tendon. It goes behind the medial malleolus and then underneath the foot. Now I could do the Babinski test. Alright, what are the findings?
Tenderness over incision and extremely tender distal first.
Palpation for tenderness is what?
Tenderness over incision.
Tenderness over incision.
Extremely tender distal first MTP and great toe.
Okay, and then tender over first MTP and great toe.
Extremely tender.
Extremely
For
tender.
distal first MTP/great toe.
Distal. Great. Toe. MTP and what?
MTP/great toe.
So, is it mention which side of the foot? Just said MTP?
Yes.
Okay.
What's the test you had me do?
Which one?
What's the test you had me do?
Which
When
test?
I just do my heel raises.
That's a gastrocnemius manual muscle test.
It says pain at first MTP with minimal resistance and heel raise
For what?
for that test.
Say that again.
FHB produced pain at first MTP with minimal resistance and heel raise.
For the soleus MMT. Flexor hallucis brevis. Pain upon gastroc. Heel raise. Which is bizarre because it's a gastrocnemius manual muscle test. Grade was 5 out of 5.
It says gastroc-soleus 5 out of 5, but it says FHB produced pain at first MTP with minimal resistance and heel raise.
Alright, so this is a little confusing because it's showing examination findings for both a tendinopathy. You're done. For both tendinopathy of the flexor hallucis longus and also flexor hallucis brevis, while also having hypomobility and hypermobility at the foot, which honestly there could be both. There could be both with a immobilized foot. So I'm going to say that there's both. So my plan of care would be to mobilize the hypomobile joint and to strengthen around the hypermobile joint as you stabilize the hypermobile joints and mobilize the hypomobile joints. I'm also going to do conservative physical therapy management for the possible, well, I shouldn't say for the possible, for the tendinopathy. There is weakness, but their MSCT was normal. So maybe just the toes are just weak in that situation. So I would want to strengthen those muscles that are weak. I would strengthen them by doing, flexor and extensor exercises, strengthening exercises. When I feel it's appropriate and the tissues have healed appropriately, I could do maybe some heel raises to kind of strengthen the plantar flexors and the really the flexors of the toe, really, and then also some of the extensors of the toe. I would also want to do those marbles, so they pick up marbles with their toes and then put them in a box or in a bowl. I want to do that. That would kind of help with strengthening and neuromuscular rehab of the toes on that left side. I might even do it on the right side, just kind of even them out. I would want to ice, and I may suggest NSAIDs. We can't prescribe medication, but maybe if there's swelling, which there is, and warmth and redness, which there is, and pain, definitely pain, or definitely ice. Maybe want to. I definitely recommend elevating while icing, and/or elevating while not even, while even they're not icing. Maybe do some compression. You can even do some range of motion exercises. Maybe just some flexion and extension to kind of help pump the blood a little bit, go back up where it needs to go. So again, what I'm saying, so then for the hypomobile joint, I would do grade 1s and 2s, maybe the first day, as well as the conservative treatment for the swelling and warmth and redness and pain, and try to build rapport with the patient, and then as the plan of care progresses, I would move into grade 3s and grade 4s. And don't foresee myself needing to do a thrust or grade 5 on the first MTP. On the first ray hypermobility, I would just strengthen the muscles around it since they're weak. Around that first ray area in the foot, I would strengthen those since those are already weak, and that would immediately have a direct impact on the hypermobility. But the first day, I'm not sure I would go into super extensive strengthening exercises. I would want to calm down the patient's foot and kind of gain trust and try to send them home feeling better, since I did a bunch of strength and length and all these other different tests to aggravate them, PRM accessory, all this stuff. So I want them to kind of feel better coming out, so they want to come back and we can address it more directly a couple days later when they come see me. For tissue activity, I would say it is, I'd say it's moderate pain at end feel. I was able to get to end feel. So if there's pain at end feel, that is moderate. If it's pain before end feel, that's high. If it's no pain at end feel, that's low. So I give it moderate for tissue activity. That is found with PRM accessory, PRM classical, MLT. Actually, no, MLT was no pain. So then I'm going to move on to subject reactivity. So subject reactivity is high for scuba diving and walking, going on walks, because the patient is unable to do that due to pain. I would say the patient reactivity is moderate, as for her occupation as a lawyer, attorney. So standing and walking she's able to do, but pain is created after 15 minutes. I believe that's it. Stated condition is, I would say acute, but acute of chronic onset. Acute onset of chronic condition because of the 6 weeks ago, but 2 days flare up, it seems like, from boot and crutches.